Good morning. Welcome to our webinar today, where we'll cover tactics to manage your risk-adjusted population. I'm Nancy Kors, Vice President of Corporate Development at UASI, and I'm responsible for innovation, product development, partnerships, and mergers and acquisitions. I'll be facilitating the session today with our experts, Colleen White, who is the Ambulatory CDI Program Manager at ChristianaCare, and Mary Stanfill, who is our Vice President of Consulting at UASI. I'll have Colleen and Mary introduce themselves directly in a minute, but first I wanted to give you a few logistics for our discussion today. We will take questions from the audience at the end of our discussion. If you'd like to submit a question, please use the question and answer, the Q&A button on the toolbar at the bottom of your screen. The chat and the hand raise feature are disabled for this session today. Also, we are recording the session, and you will get a copy of the recording tomorrow via email. But before we get started, I wanted to give you a little bit of background on UASI for those of you who do not know us. So UASI is a privately held services company that has been helping health systems with their mid-revenue cycle since 1984. We create value for our clients by providing insights, innovation, and making an impact to their operation. As you can see from our logos here, we show that we've earned the right through that value creation to serve a number of leading hospitals, and 80% of our clients have been with us more than 20 years. Our expertise and our capabilities that we focus on in the mid-revenue cycle are around clinical documentation integrity, coding, and revenue integrity. What we love about how we operate is we engage the way that works for you. So we can provide staff augmentation, whether that's short-term or long-term. We can even provide managed services through outsourcing agreements where you can outsource the entire department, or provide temporary leadership or interim management solutions for you in coding, CDI, or revenue integrity. We also can approach based on a problem on a consulting and project-based engagement. So if you're trying to tackle a specific problem, you can engage us to help you solve that problem. And finally, we've recently introduced some revenue optimization and risk mitigation technologies around risk adjustment programs, which you'll hear a little bit more about today. So now I'd like to hand it over to Colleen to do a quick introduction of herself in ChristianaCare.
Thank you, Nancy, and thank you for allowing me to participate today. Again, my name is Colleen White. I am the Ambulatory CDI Program Manager for ChristianaCare. I'm a registered nurse as well as a CPC, as a certified coder. I have been with ChristianaCare for 21 years and in the CDI program for about 2.5 years now. And who is ChristianaCare? So we are a regionally based academic health system. Christiana is actually the largest healthcare provider in Delaware and also the largest provider of healthcare in the Philadelphia region. We have been serving our community for more than 100 years. And we're also the largest private employer in Delaware. We do have 3 standing hospitals as well as a freestanding ED. We are a regional healthcare center for excellence in heart and vascular, stroke care, cancer, and women's health. And we do have more than 120 primary care practices in the area. This is a slide that just shows you some of the accolades that we have achieved over the past several years. We have been America's 50 Best Hospital in 2022, and that is ongoing for multiple years now. We are the region's best hospital, according to the U.S. News and World Report in 2020 and 2021 and 2022, as well as many other accolades. So thank you, Nancy.
And good morning, good afternoon. Hello to everyone. This is Mary Stanfill. Thank you for joining us today. I am Vice President of Consulting for UASI, and I've worked in healthcare in the revenue cycle space, specifically in health information management and informatics my whole career. I'm a bit of a data geek, and I've focused on coded data, data quality for many years now. Most recently, that focus has been on HCC data capture, as we've been working with our clients to help ensure accurate risk adjustment data, which is what we're going to discuss today. We are working with healthcare organizations across the country, helping them adjust to value-based payment models, particularly risk-adjusted models, which require adjustments in documentation, coding, and reporting. So I'd like to introduce the UASI risk-adjusted maturity model. We developed this model to serve as a guide for health systems and provide a way for health systems to see their progress as they're making these changes to address their risk-adjusted populations. The model is relatively straightforward with a progression through 4 key phases, and we'll talk about those more throughout our conversation today. Just at a high level, as a summary, every healthcare organization's risk adjustment program might look a little different, but there are core strategies, some key tactics that are common among the successful programs. And the risk-adjusted maturity model outlines some of these strategies and tactics, illustrating the progression of a program from wondering what your RAF score might be to having confidence your RAF score and your risk-adjusted payments are accurate. Knowing which phase of maturity your organization is in can really help guide your next actions. But the model's not intended to be linear, and the phases aren't necessarily mutually exclusive. You might be advancing in one area versus another, and you might circle back to strengthen a tactic or emphasize a particular strategy in order to make the next leap, you might say. So the model is useful throughout the life of your risk-adjusted program as your program grows and evolves. And I think that's what we want to just talk about today, is just that process of how Colleen's going to share how her program has grown and changed, and challenges and lessons learned. And then I'll do the same, sharing from some of my clients. Nancy, you want to guide you are on mute, Nancy.
You know, when you think you hit the button, it doesn't work. But
Right.
So if anybody's wondering, you had to have this haircut to participate on this panel today. So, so if you get us all confused. Anyway, thanks for that explanation, Mary. Colleen, I want to start with you really with understanding where you think you are in the model, right? And what phase you're in and why you think you're there.
Sure. So I truly believe ChristianaCare has come a long way in our ambulatory CDI journey. And I believe we are firmly rooted right now in the optimized stage. And when I look at this model, I really look at it from a PDCA perspective. So like Mary said, it's a fluid model. There's not one, it's not linear, it's more circular. So as you continue to optimize, you're going to evaluate where you are. And then you may fall back into that implementation phase as you look at your processes and are they working correctly? And if not, let's go back and reevaluate that. So ChristianaCare has really moved to this optimization phase at this point. We've implemented processes, people, tools, and we are continuing to evaluate whether those tools are working. We have clearly defined organizational KPIs for the first time in the life cycle of our ambulatory CDI world. We are now focusing on optimizing what we have implemented. So the first time ever, we have for fiscal year 23 tied provider incentives to redocumentation of HCCs, which goes a long way in provider engagement, which is what we need for driving this HCC risk capture. And then partnering with our payers to make sure that the correlation of data is accurate. When they report out to us what they're showing as their internal risk scores for our population, does that data correlate with what our numbers are?
Thanks, Colleen. So how long have you been at it? Because it's not an easy process, right? It's not an overnight thing. I'm just curious how long you've been at it to get to that optimized phase.
Sure. So we have, our journey began in 2016 with a concept meeting. And really what we did is identified an opportunity as we started to move towards more value-based contracts. How do we optimize our risk scores? How do we optimize our HCC redocumentation for those value-based contracts? Our pilot originally included 16 of our primary care practices. In 2017, we added one FTE CDI, so we had a successful pilot program. And then from 2017 forward, we've continued to grow, add new team members, add new processes. Try a process, didn't work. Let's try something else. And that's what got us to where we are today.
Great, thank you. So Mary, what I want to do is switch to understand the model, and let's break down each phase a little bit. Can you talk to us a little bit about what happens in that explore phase and what challenges do health systems typically have in that phase?
Sure. And it starts just as Colleen said, at the explore phase, they're just starting to get their arms around what are our RAF scores. So a health system is setting out to discover how to address their risk-adjusted population. They might know their RAF score, might not know, their RAF score in real time, probably relying on payer reports that have a significant lag time. If their average RAF score is below 1, they're pretty sure it's too low, but how do they confirm that? How do they fix that? So they're at this point where they know they've got they're a growing risk-adjusted patient population, and they know they need to do something about it. But they don't really, they just are getting started. They need to explore that, and not sure to what extent their documentation is accurate and their coding reflects the true severity of their patient population. I think one of the biggest challenge when you're at that point is where to start. Typically, we're talking about the best opportunity to affect that is in an ambulatory care setting. We're talking about several thousand patients, probably tens of thousands of visits. You can't possibly simply import inpatient CDI practices into that kind of a circumstance. In the inpatient arena, we review 80 to 90% of the patients that are in a bed, and you cannot do that. So where do you start? How do you prioritize? How do you begin? And it, that really takes some initial discovery and some data analysis to get started.
Great, thanks. So Colleen, I'm curious, what was the impetus to have ChristianaCare get started on this journey?
So again, it is that movement in the payer world to move to those more value-based contracts. CMS has a tendency to be the forerunner when it comes to things. They implement something new, and then lo and behold, maybe a couple years down the road, commercial payers tend to adopt those same things. So when CMS started talking about value-based contracts and reimbursement based on the care that the patient receives rather than fee-for-service, that's when health systems started to look at how can we optimize this work now that we're at risk, we're financially at risk for the care that we're providing to these patients. So that was really the impetus. And then the stakeholder or the champion that really drove this was an inpatient CDI that was a front runner and really identified the need in our outpatient world and our ambulatory world for this similar process. So she was really the champion that really drove this pilot forward.
Great, thanks. So Mary, is this pretty common what you're seeing? Because I know that you work with a lot of clients. I work with you with some of the clients, and we hear this whole, they know they need to do something, right? They haven't quite started. They don't necessarily have a champion. What's common? How do they decide now's the time?
Well, really usually is the key driver really is reimbursement, some impetus for that, where we've had instances where a client would call us and say, we didn't achieve our shared savings, or in an MSSP model, or we've looked at our numbers and there's a problem, right? That's the reactive approach. The proactive approach, best circumstances where you're aware of, we're in the process of negotiating risk-adjusted contracts, and so you get ahead of it, which we've had the pleasure of working with some clients doing that as well. So it's usually, right, you're either being proactively addressing it or reacting to these reimbursement problems and concerns and looking for solutions. And it's very common, as Colleen mentioned, they had a person, an inpatient CDS and that she mentioned who really just went after it, took the initiative. And we do see some of that as well, where the a CDI program in a health system will be tasked with expanding. That's also a common avenue. And then they're looking for strategies because they pretty quickly will find that the tactics that you employ in an ambulatory setting are very different from those that work well in an inpatient setting, for example.
Great, thanks. So let's move to the define phase. Mary, maybe you could summarize this phase for us as well and talk to us. Is this where most health systems are today, or do you think more of them are in that implement and optimize phase?
Yeah, they're more in the middle here. So at the define phase, the health system is beginning to really review their risk adjusted patients to identify what the potential is versus the actual RAF score and really get their arms around that. They're looking for ways to prioritize patients for review, to make sure that any effort that they're going to spend in documentation integrity is worthwhile. So they're beginning to potentially maybe experience the frustration of trying to review charts and record those results and do something with that information that they're learning and starting to try to understand the priorities, the trends, that sort of thing. I do think this is the point most health systems are is in that define, somewhere in the define, maybe up and starting to try to implement. They're using Excel to try to manage chart reviews that they're doing and follow-ups actions that need to be taken based on the results of reviewing charts. They're trying to figure out how to embed physician queries into that ambulatory care setting in a clinic setting, starting to try to solve some of those problems and really figure out what their processes ought to be so that they can implement, and maybe trying some things. They might implement a pilot, right? And that's probably usually part of your define phase is you try some things.
So Colleen, how did you know you were progressing to this phase? What were the indicators that said, okay, we're past this explore phase, right? We're moving into this define. What did that look like for you?
So I think the key for us was really the point when we realized that we needed a more targeted approach. Like Mary said, you try one thing, it works for a while, but then when you start to reevaluate it, you realize that you need to shift your focus a little bit. So two of the key things for us was really realizing that we needed that more targeted approach. How do we accurately reach the population that we need to reach? The second part of it was not having to rely on payer data. We wanted to be able to get to the point where we could rely on our own internal data rather than getting that information from the payer. And I'm sure that there's many people on the call that understand you may have 3 or 4 payer partners that you're in a value-based agreement with, and none of them give you the same information based on the same reporting timelines and the same runoff. And so it's really difficult to try to chase those numbers because you're never comparing apples to apples. So when we looked at our targeted approach, we really started to identify areas of opportunity, what the industry likes to call low-hanging fruit, those diagnoses that are commonly misreported, whether it be missing an opportunity to link your diabetes to your CKD when you jump from HCC 17 to HCC 18. The other side of that is accurately reporting. So not only do we want to increase our specificity whenever possible based on accurate clinical documentation, but we also want to mitigate our risk. So we started taking a look at those diagnoses that are often misreported in the wrong direction. So we don't want to capture a DVT or a PE when it's truly a history of. We don't want to capture those strokes in an outpatient setting, the cancers that are active versus history of. So we started to take a look at those areas of opportunity to mitigate the risk for the health system as well.
And I want to add something to that before you move on, Nancy. Colleen, I'm really glad you mentioned that about the information we get from the payers, right? Because I think that's one of the things that holds up a health system and keeps them sort of struggling to truly implement a comprehensive program is you really do need your own data. You can't, of course you want to leverage the data you're getting from the managed care plans, but it's you get a lot of different information, different formats, different times, super hard if that's the only information you have. You really need real-time data about your own patients. You need to be able to calculate the scores. You need to be able to evaluate the coding and documentation results closer to real time using your own data, and not discount that information you're getting from the payer. You want to pull that all together, and the ability to do that takes some pretty sophisticated tools that could really hold some people back. As long as we've worked with a lot of clients where they just can't get their program off the ground and really get going and make the improvements they want to make, because that is getting in their way. They're reliant on and pretty much dependent on information coming from their managed care plans.
And using Excel, right, to manage all those patient encounters. All right. Well, let's move on to the implement phase. And Mary, if you could talk to us a little bit about what happens in that phase, and what are the typical indicators that somebody might have arrived right at that phase?
Yeah, I did. And I meant to comment on that probably the number one biggest challenge in that defined phase is the Excel nightmare. So when you get to the implement phase, the health system is moving beyond a pilot test with one, maybe two people doing some chart reviews. They're beginning to really establish a consistent programmatic approach. So they're developing procedures that they can reproduce across multiple clinics or multiple provider groups. And maybe they've even got a cross-training program. They're cross-training, they're growing their team, they're getting a larger team to carry this out. So at this point, really in that implementation, to be at that implementation, to really launch your program, you definitely need data analytics. You need database tools to enable the team's efforts. You need KPIs, ideally shared on a dashboard, those kinds of tools to really have the right people, process, that sort of thing in place to carry out the program. And that's what we mean by implement.
Yeah, Mary, can you also comment? I know we were talking to a client the other day and they talked about, and this goes to that data, right? That everybody has access to the data at the same time, the same data, the same version, because they're emailing, right? They're flipping around. As soon as I send it, it's outdated. Can you talk a little bit about that workflow that needs to be in place?
Yeah, because you're doing ideally, some of that we have established best practices. So ideally, I talk about this bookended approach where you're doing pre-visit review. That's as close as you can get to concurrent, to real-time kind of documentation review to make sure that the complexity of the patients is being evaluated and is being documented appropriately. And so you've got a process in place. You're starting to have some people review some charts. And there, as I said earlier, there's thousands of visits, thousands of patients. So you're using the visit schedule, some targeted approach to, and some rationale, right, priorities to decide which patients to review pre-visit, and then working with the doctors, maybe, kind of, we call it curbside or real time, to give the doctors input and heads up, on things to check and pay attention to when that patient comes in for a visit. Well, you have to record then the fact that you've done those things and keep track of what actions did we take. If you ask a provider to adjust something to make sure that they address a particular chronic condition. It's, the example you gave, Colleen, was a great one with identifying those chronic conditions that are, as patients, unfortunately are progressing perhaps in a chronic diabetic patient. And providers don't know that there are combination codes for that, and that they have to connect those dots and that sort of thing. And so you're putting these processes around them to help, but keeping track of it. The actions that might result from those chart reviews is indeed, maybe there's a query, and then you're asking a physician to address something, and then you want to close the loop and follow up on that and make sure it gets done. Or maybe a patient needs to be scheduled for a visit or a repeat GFR to check their CKD progression, perhaps. So these actions need to be taken, and keeping track of that. Handing the baton, you need appointment scheduler to follow up. You have to get information to multiple different clinics, and you're trying to pull together the clinic directors to help you with that. So the coordination and the communication is super important, because you have to have a team working on this. And working in disparate Excel files, multiple Excel files, very quickly, as you can imagine, you end up with a lot of, follow-up points, touch points, opportunities. And how do you manage that? How do you keep track of that? So I think that's the complexity. That's the problem people find themselves in.
Great, thank you. So Colleen, how did you guys attack this implement phase?
Yeah. So Mary, I just want to say thank you for calling out 2 points. I do want to say that even though ChristianaCare is really in this optimization phase, we are still living in the Excel world. So I can feel that pain. When I started in this role, we were working off an Excel spreadsheet that was 9,000 lines long, and we're still living there. It's not quite 9,000, but we're still living there. And really that communication that you mentioned a few minutes ago is so important. And the key to that, we're talking to our quality team, we're talking to our outreach team. And sometimes what gets glossed over is the most important relationship, and that is with the provider. And really provider engagement is the key to this whole process. So I just wanted to say that as an aside. So Nancy, to address your question, how did ChristianaCare tackle this? Very similar to what Mary said, we started with one person in a pilot, and the pilot was deemed a success. So we added a second person, and then we started doing those prospective reviews. Where do you start? And we didn't have any platforms, any HCC tools available to the providers in their workflow. So it was prospective, digging through the charts, trying to figure out, find those nuggets that we can forward face to the providers in the way of a query. And then in 2019, our EMR platform started to introduce some natural language processing intelligence that would forward face those HCCs to the provider. So that kind of gave us the ability to reevaluate our work and shift from that prospective process to a retrospective process, where we were looking at the records after the visit occurred to make sure that the documentation truly did support the diagnoses that were being presented on the claim. We are now kind of in a hybrid model, like Mary said, a bookend. I like bookend. I call it sandwiching the provider in between. Bookend sound a little bit better than sandwiching. But really, that's what the goal of the CDI team is, to support the providers from a prospective standpoint as well as a retrospective standpoint, to really tee them up for success and making sure that they have all the tools necessary to be successful in this work. But not only have the tools available, but teach them how to use the tools appropriately. And lots of growing pains. So I liken it to toddlers. When they go through their growth spurts, there's pains involved in that. And there's a lot of growing pain in the implementation phase. But if you can do it in a stepwise fashion, the gains are amazing.
Can you talk to us a little bit about some of those successes that you've had? What are some of your proud moments right through this phase?
Absolutely. So one of our, at least from my perspective, one of our proudest moments is our provider education program. I am a very strong proponent of provider education. Again, that provider engagement, we need that in order for our value-based contracts to be successful. We can teach the providers how to document diabetes with hyperglycemia appropriately, but if at the end of the day, it's still the provider's responsibility to do that work. So we definitely need that engagement. We have, as part of our education program, developed what we call a one team, one message. So we have a tip of the month that we build together as a team. And all of the providers get the same message. No one on our team deviates from the script at all. We truly feel that if we want the providers to be consistent in their documentation and their recapture of HCCs, then we need to be consistent in the message that we provide to them. So everything is uniform. We have revised all of our query templates, so they're templated in a standard format. We've also instituted annual education. It's rolled out to the providers on an annual basis. It is part of their learning space. It is a mandatory education for all of our primary care providers to pass with 70% or better. And we're super excited about that. And then again, just as we continue to grow the team and as we continue to be consistent in our message, it's just so rewarding to see that increased provider engagement.
So I'm going to ask you one more question before I move to Mary. You've made some mention about, you started with one person and did a pilot, then you added another person, right? And sort of your process and tool evolution. Mm-hmm. What's been the big impact around that? Like that evolution, like how did the work impact your staff? Obviously it grew, right? But also how you actually operate.
Sure. So we have grown exponentially. So I said, we started with one and then they added a second CDI in 2017. In 2019, they actually grew the team from 2 to 6. So we added 4 additional CDI team members. And that's when I became part of the CDI world here at ChristianaCare. In 2021, we moved to a hybrid model. So just last year, we moved to that hybrid model where we were teeing the provider up for success with that prospective review.
Did we lose me or lose?
Okay, Colleen, are you there?
Oh, darn, we lost her.
Well, this gives me the opportunity to move to you, Mary. She probably needs a drink of water anyway. So
she might, yeah.
Go ahead and move to you and hopefully she'll be back with us as we ask you this.
Yeah, and we'll just let her jump right back in where she was and continue bragging. They really have done a lot with their program, which is why we were so delighted she joined us today. Still just in this implement phase, some practical, right? Some pragmatic tips and things for folks. What I would say is where people usually start is in primary care. They pick a clinic, they pick a group, maybe someone who's, a group of physicians who have interest, who have some skin in the game, have a lot of, Medicare Advantage patients that they're concerned with. So you start someplace where you believe you can be successful, right? And you do some things, you really start to make some progress and you learn from that and you learn what people respond to and what to do. I think some of the successes that we see that work in that when they're implementing is, you need some early wins to gain buy-in from people, and just from a sort of classic change management perspective, to the extent that you can demonstrate progress, some early, low-hanging fruit, I call it, then you get people on board and you get people excited about it. And just the ability to start monitoring and managing, starting to show what you can find. What we see is generally in a program, initially the efforts are focused on recapturing, making sure that patients who are chronically ill, that you aren't missing something and under-reporting something you're aware of. So you look for instances where an HCC that has been captured, a chronic condition that has been captured year to year, doesn't get missed this year. those recapture efforts, we call it, is some of the low-hanging fruit, and that's usually where programs start. And then you move on from there to once you've really mastered that and you've achieved a pretty good recapture rate, then you move on to start to really identify chronically ill patients whose conditions have been they've been regularly underreported, never reported maybe. And there's a lot of those. And that's where it really begins to really, really resonate with providers, because now you are enabling them to do what they want to do, which is keep their patients healthy. And you're helping them to recognize patients who have chronic conditions that need more attention, need more healthcare services, need their help, right? So that gets really rewarding. Colleen, we lost you there for a little bit. I'm glad you're back. Pick
I
up right where you
apologize
left
for that.
off. You were bragging on some of the things that have worked well.
Yes, I apologize for that. So yes, so we definitely have had an opportunity to celebrate our successes, and like Mary said, we're starting to move away from just looking at those low-hanging fruits to how can we optimize the work that we do? How can we have a more targeted approach to our prospective review process? How can we prioritize our patients that need to be outreached? So we're starting to partner with our outreach team, and then really starting to look at our data from our payers, do deeper dives so that we really truly understand the discrepancies in what the payers are reporting out to us versus what we're seeing in our internal measures. So and that's kind of where we've been able to identify where we want to move to and how we're going to optimize the work that we do.
Great, thank you. Welcome back.
Thank you. Sorry, I'm so sorry about that.
That's all right. So Mary, Colleen had mentioned too the evolution of the EMR, right, in this, and what is the role of the EMR, and how can somebody leverage that as part of this process?
Yeah, I'm glad you asked that, because it's really important to do that, right? I mean, an EHR is a super expensive tool, and you really need to fully leverage the information you have on your patients to truly enable population management type reimbursement models like this risk adjustment. So the EHRs have some great tools. Epic has the Healthy Planet module, the HCC Refresh, Cerner has the Diagnosis Insights tool. So these tools can help you to recognize and identify, hopefully, the patients who indeed are meeting certain clinical criteria, potentially, to the extent that you can do those kinds of searches using clinical data. Or simply, Epic has the ICD codes embedded, searching for those, and making sure you are aware of the patients who have certain chronic conditions. And I think these tools, we've seen them evolve. The EHRs are adding more and more tools. We've seen them evolve dramatically over the last, 4 to 5 years in terms of being able to help manage patient populations and identify patients with certain cohorts of patients with certain chronic conditions. Super helpful. And so that's, one of the first places to start, and certainly use the EHR to the full extent. I will say, though, that even with those tools, our clients are still using Excel, right, to capture outside of the EHR. So the EHR is the electronic health record, right? It has the information, the clinical information about the patients. And then there's this whole need to enable the work of the CDS, to enable the outpatient CDI program. That work effort requires also some tools. And just like you need tools to enable the work that you do every day, there are tools that your CDI program needs to enable their work. And that's where we end up in this. Without that, we end up just struggling with Excel. So I think, that's one of the common sort of challenges I see, is the inefficiency that Excel causes. And it can cause a lot of starts and restarts. You're trying to do some effort. You've got an Excel file with 9,000 rows, or maybe we've seen some of the most sophisticated Excel files, trust me, a tab for every month, or an Excel file for every month or every week. And they all have follow-up actions. Every row is a patient with follow-up action items on it. So one of the common sort of challenges we see that people get stuck in the implement, maybe they're sort of 2 steps forward, 1 back, and they can't move forward to truly optimize their program, is when it's just a problem when a decision maker, as decision makers in the health system, see all these EHR tools and they believe they have everything they need in the EHR, but meanwhile the CDI specialists are spending hours recording their work in Excel. So that is going to hinder true population management approaches. So you do need the tools outside of your EHR to enable the CDI program's work, recording the CDI findings on the chart reviews, and the actions that need to be taken. These aren't functionalities of an EHR that is embedded in the EHR. You need some sort of HCC audit software to really address that and prevent the expensive inefficiencies and the stumbling blocks that keep you from being able to have a sustainable program. Did I answer your question, Nancy?
It did.
Okay.
For sure. And I saw Colleen shaking her head a lot during that one. So we have about 20 minutes left, or a little less than. So I want to move on to this optimize phase. So Mary, could you talk to us a little bit about that, what that phase entails? And Colleen has talked a lot about this phase since she's in that phase, but just curious for people who haven't been through this yet or aren't at that phase, how should they think about it?
Sure. Well, at the optimized phase, the health system really has established a program. They've got consistent policies and procedures, and they have ways to monitor their performance. So they've probably solved, as we sort of mentioned, they've solved some of the low-hanging fruit, the easier problem, if you will, of recapturing previously identified HCCs year to year. And now they want to move on to ensure that they've captured the chronic conditions for their patients that haven't maybe been previously reported, the true gaps, if you will. So they need to know they're starting to do things like pay attention to the prevalence of chronic conditions in their region and confirming that they're at least trending on par with that. At the heart of this, you need to know that your patient population is being cared for and reported correctly. So to do that, they're monitoring their patients, their trends, their provider trends. They're able to identify who are the sickest patients, the most expensive patients, which patients need more attention to keep them healthy, which is the whole goal, right, of value-based care and this risk adjustment model that we're trying to adjust to is to keep patients healthy longer. So which providers are the top performers? And they're really great documenters and they're doing really well and they could serve as role models. So this ability to do this trending and really start to use their data, which is a lot of what, as you said, Nancy, Colleen's been talking about.
Great, thank you. So Colleen, I know you've talked a lot since this is where you are. What are your priorities since you're in this phase? And are there certain KPIs, right, that you're always looking at and monitoring that people should be aware of?
Mm-hmm. No, that's a great question, Nancy. So we are, one of our priorities right now is developing a tool for accurate CDI data. Like Mary mentioned, the EMR is really driven to the providers. Forward facing those HCCs, what's been captured, what hasn't been captured, using those tools. Is the diagnosis on the problem list in red or is it in black? So those key visual pieces that forward face to the providers, but that gap is really the CDI work. What are we doing to support the providers? So we're beginning conversations about using tools that are in our EMR to accurately capture that CDI data. How many queries do we send for the stage of CKD? How many queries do we send to further specify major depressive disorder? Those are things that we're still tracking on those Excel spreadsheets. So we definitely have some work to do to recircle through this timeline and this process. How we have identified the issues. So now we've defined it. We've gone back a little bit, a couple steps to that define, and now we're working on ways to implement new ideas, really to move away from that Excel. Automating our processes, again, with that data capture, automating that data capture so that we're not auto summing totals at the end of the month on that spreadsheet. Code corrections. We've been working with our patient financial services team to automate a process when we do our post-visit review and we're going to make changes to the coding on that record. How can we do it in an automated fashion so there's less manual work involved? One of the key pieces that I can't believe I didn't even mention until this point, and I'm sure that there's other people on the call that have the same pain point that we do, but ingestion of the CDPS model, our Medicaid population. So many times EMRs focus on that V24 model, that Medicare model, and any tools that are embedded in the EMR generally focus around that. So how can we stand up a CDPS model platform that's going to be beneficial to us in the CDI team, but also to the providers? How can we identify those gaps for that population? Because we do have value-based contracts surrounding our Medicaid population as well. Growing, ChristianaCare is growing. So how do we make sure that we support all of the new primary care practices that are coming on board? All of our specialty practices. Our CDI team not only supports our primary care practices, but our specialty practices as well. So continuing to educate the specialty practices on this HCCs that are specific to their specialty. And then I mentioned a few minutes ago, partnering with our outreach team to really identify the sickest of the sick of our population, or those patients that are lost to follow up, making sure we get them back in so that they are getting the care that they need.
As you grow and bring new practices on, specialties or groups of physicians, are you also focusing on working with them kind of in their own little pilot, right, as you get them onboarded to the program, or do you have a process for that or a priority for that?
Mm-hmm. So we do have a very comprehensive onboarding program for our new primary care practices, and we have I don't even know how many slides are in the slide deck to really teach them what HCCs are and the role of CDI. But we do kind of, I don't want to say throw them into the deep end because that just doesn't sound very nice, but we don't do a stepwise approach. We do a very comprehensive onboarding, and then this is what we do, and this is how we're going to support you. And starting next week, that's going to happen. But we do supply, like I said, those tip of the months. A lot of our tip of the month are around disease processes and how can you improve documentation and accurately capture those conditions that they're already doing. I tell the providers, you're already doing the work, and what we want you to do is take credit for the work that you're already doing. You're managing that diabetes with chronic kidney disease. You're not managing diabetes without complications. So document it correctly so that you can take credit for the work that you're already doing. And so when we onboard new practices, we throw them right in, and we do follow up with them on a more regular basis in the beginning to make sure that they're really in line, their documentation's really in line with where it needs to be. And honestly, we find that our new practices are really good. And I don't know if that's just because they're new to the healthcare system, so they come in maybe with some rose-colored glasses as opposed to providers that have been in the healthcare system for a long time. But we find that we have really good new practices on board. So we're pleased with that.
Great, thanks for that. So we're going to open it up. I do have a couple questions from the audience. We have about 10 minutes left, so we wanted to open it up to Q&A. And Colleen, I'm going to start with you. because there's some curiosity out there about where this sits in the ChristianaCare organization structure.
Mhm.
And do you see pros and cons with where you sit in the structure?
So that's a great question. And that is actually something that we have been tackling within the past, I want to say 3 to 6 months within our CDI team and within Christiana. So we do have an inpatient CDI team that sits in the hospital world, in the inpatient realm. Their reporting structure is with our committee and our team, case management team, as well as with HIMSS. Our outpatient CDI team does live in the world of our outpatient program. So we fall within what ChristianaCare calls our medical group. However, in the past 3 to 6 months, we really have started to partner with our inpatient CDI when we've been doing policies and procedure reviews to make sure we're in line with our problemless correction policy, making sure that while our scope of work is a little bit different, inpatient focuses on DRGs and MCCs, and CDI focuses on HCC world. There is some overlap. HCCs are captured in face-to-face encounters, and hospital inpatient stays certainly meet that criteria. So we want to make sure that we're partnering with our inpatient CDI to make sure that we're really doing the best we can to serve our patients.
Well, it's actually kind of funny. You got to another question that's in the queue, and that is around if you are an inpatient, right? And you have an outpatient group that's focused on this, why would you need to know or care about this if you're on the inpatient side?
Sure. So I definitely think that it's important to know, just because we're all still CDI specialists. We all are still involved in clinical documentation integrity. So while it doesn't necessarily need to be a primary focus of the inpatient CDI world, it's nice to have an understanding. So when you see documentation on the medical record from the ambulatory CDI, you have an understanding of what that means and what impact that has on the health system from a reimbursement standpoint.
And I would just add to that, we do chart reviews across the whole continuum of care at USI, and review 100,000 records a year. Lots of chart review. And what we're finding is that the HCC capture and making sure that chronic conditions that correlate to HCCs are documented and coded correctly, that is an element that's being added across the board and could be added to any encounter. But the thing we need to keep in mind, the distinction is that DRGs are encounter based. It's an episode of care, an encounter that the DRG the payment is driving, and HCCs are patient-based, longitudinal across the whole year. So you might document that particular diabetic, we've been using that example, Colleen, the diabetic chronic complication very well on, in one instance. And that is really what's needed. If you've captured that this year, you've captured that. And so every opportunity to do that, we kind of look at the inpatient record as kind of the golden record, right? It's a great opportunity. Some of their best documentation, in fact, is in those inpatient records to support the patient's conditions. And so that's always helpful. So we're, even in our inpatient reviews, we're starting to incorporate those chronic conditions and HCCs and capturing them there as well, because it can't hurt, right? You definitely want to, as you said, Colleen, always document to the extent, demonstrating the care that you're truly providing and the care the patient needs. But it's hard to measure without looking at the patient across the whole year. So if you capture an HCC on a particular encounter, it also might have already been captured on another encounter. And so maybe from a financial perspective, you've already addressed it, or maybe not. It's just good to always catch it each time. But unless or until you have a tool that can calculate the patient's RAF score for the year and the impact of that code, then it's kind of tough to know what the impact is. So that's kind of the distinction and the difference in the approach when you're working with an inpatient chart versus an ambulatory care record, or trying to look at the true risk adjusted score for the year. Hopefully that helps.
Yes. So Mary, I have one more question and then we'll do a quick wrap up here. But for a health system that knows they need to do this, but they haven't quite committed to it, where would you start?
Well, so when someone comes to us and says, we're starting to have these, patients in this risk adjusted space, what should we do? Usually the place where we usually start is by looking at their data. So, and I would say, first you want to we'll do some data analysis to find out what their patient population mix is, where their opportunities are. We can do some initial gap analysis and really find out where the priorities are, where the opportunities are. And then based on that, you can identify where that low-hanging fruit truly is, because you need some early wins. So we do have, we have a mechanism to do the data analysis, to find those target areas and then help to prioritize, because I think that's the biggest problem that people struggle with is, because they've got so many thousands of patients, and where should I start reviewing them? So it really has to start with the data. Okay,
great. So I'm going to sneak in one more question, and I'm going to ask Colleen this, right? So Colleen, the question is, you mentioned capturing history of DVT codes negatively affecting RAF scores. Can you please explain that?
Absolutely. So DVTs, PEs, cancers, strokes, I'm going to talk about them kind of in general, or answer all of them in one question, or in one answer. So those conditions, or those complications, acute conditions, all risk adjust. So if a patient has a DVT, there's a coefficient that's associated with that HCC category that is an additive factor to the patient's risk score. However, a history of DVT does not risk adjust. So if a provider is documenting active DVT when it's truly a history of, then they're inflating the patient's risk score with an inaccurate risk capture, or HCC capture. So to mitigate the risk of the organization, we want to make sure that doesn't happen. The same thing with cancers. History of cancer does not risk adjust. However, cancer does. As a matter of fact, secondary cancer, so metastatic disease, is the highest HCC, one of the highest HCC coefficients in the whole V24 model. So not only do we want to make sure that we are not documenting cancer when it's a history of, but we want to make sure that we're accurately capturing that metastasis if it's there as well. So that's why when I mentioned DVTs earlier, I'm talking about risk and potentially negatively impacting the risk score. So I hope that answers that question for you.
I'm really glad that question came up, because we talked a lot about recapture, but the goal is accuracy, right?
Yes.
And there are a lot of that low-hanging fruit includes, acute conditions. And when I talk about data, starting with the data, there are aberrant data patterns that you can chase, that you can follow, that will be really evident of some areas that need documentation or coding improvement. And, a classic example is a patient who has an acute stroke in the clinic every month, 8 times this year. Those are aberrant coding patterns where that acute stroke code is just being carried forward.
Yes.
Colleen, we're beginning to see why your slide deck is so many slides you can't count, right? When you're educating the organization on this.
Nancy, I want to jump in and answer a quick question that I saw. Someone's asking, do we use RNs or for this outpatient CDI work, or coders? And the answer is both. It really requires the clinical expertise to recognize the clinical indications. I'm not going to be able to, I am not a clinician, I'm not an RN, I'm not going to be able to review, the GFR lab values and recognize or even anticipate when it's appropriate to check on whether a patient is moved from CKD stage 3 to stage 4 to stage 5. And that movement changes their risk adjusted coefficient, as Colleen was saying. So it does require clinical knowledge and clinical expertise working with the providers to help make sure that the documentation is accurate. At the same time, there are very specific, a lot of coding requirements. There's a lot of combination codes and there are, those combination codes make a big difference in the hierarchy, in how the coefficients work and how it risk adjust and getting that accurate. So it really does require a partnership. And we see a lot of, we're doing a lot of teaming very intentionally with, the RN, outpatient CDI specialist who's an RN or has that background working directly with coders, RNs that are getting their CPC, that are learning the coding requirements, and they're working together and teaching each other and doing really, really great work.
Okay, so we're just about out of time. Just one last quick question for both of you. So Colleen, if there's one thing for our audience to keep in mind as they build their risk adjustment program, what would it be?
Learn how to dance, because you're going to be pivoting, you're going to be shifting your focus, you're going to be looking behind to see what you did, where you are, how you can do it better the next time around. So be flexible and be willing to learn.
Thank you. So Mary, any final words of advice from you?
I think I would say in a nutshell, try to give you a nut graph, leverage your EHR to the full extent. It's an expensive tool, use it to the full capacity, but don't make the mistake of thinking your EHR has all the tools you need. Look for ways to increase efficiency in the CDI process itself. So my recommendation, ask your staff to share any Excel files they use regularly and look for software or database solutions for those complex Excel files.
Great. Well, Colleen, Mary, thanks so much for your sharing your expertise on this topic. I know that this is a new topic for a lot of people. They're just starting to dig into it, and there's a lot of learning and growing. I think that all health systems are going to do around this over the next few years. So thank you to our audience for your time and attention and your great questions today. Sorry we couldn't get to all of them, but we will certainly follow up with you to help address those questions that you have. Just a reminder, the recording of this session will be sent to your email tomorrow, so you can get that. But in the meantime, if you're interested in learning a little bit more, we have a 3-minute checkup on our website that you can see where you fit into this risk-adjusted maturity model, and or download our white paper at uasisolutions.com, so you can see some more detail around each of these phases. So thank you again for your time. We appreciate your attention.
Thank you, Nancy.
Thank you.